All right, our next segment, we're going to talk foot and ankle with Dr. Mark Nathanson. Dr. Nathanson is a doctor of pediatric medicine with the foot and ankle division of Rothman Orthopaedics. Thanks for taking some time here, Doc. Your topic at ATSNJ this year was common foot injuries in dancers, and you really did a deep dive into some of the most common problems that you've seen in your practice, and with some really great takeaway tips for the athletic trainers. And I really want to focus on three key areas that I think are the most prevalent that you brought up. The first being Achilles tendonitis. And one thing that was interesting is you said about the differences between non-insertional versus insertional. Can you speak to the difference between these two, kind of what you meant, and really how that drives treatment?
Sure, Ryan. Thanks for having me, by the way, and thanks for the invite to the conference. I had a good time. I wanted to point out, because insertional versus non-insertional Achilles tendinosis, they're treated slightly differently. And there's also a different patient dynamic. You'll find that the non-insertional, which is the most common one that, we'll probably get in our clinics, which is the sort of the mid-tendon region, swelling, pain, all that kind of stuff. We consider that the non-insertional, and that's going to be the younger athletes. The healthier tendon tends to get the inflammation in that non-insertional mid-range area. And we also note that as the high water mark, because that's the area of the Achilles tendon that has the least amount of circulation. And doesn't matter your age or who you are, everybody's the same. But in the younger, more healthier tendon, that's going to be the area that's going to be sort of more at odds for an injury to our athletes. And also what's important about those non-insertional areas is if there's a rupture, and again, it's the younger athlete will have a rupture in that area. Those, depending on the amount of gap, sometimes are fixed surgically, and sometimes they're non-surgical. Depending again on the gap, 2.5 centimeters is usually the gold standard. Anything above that, we typically will fix surgically. The insertional Achilles tendinosis, the inflammation where you're not going to feel it necessarily at that mid-range of the tendon, but when you take your thumb and forefinger and come down towards the calcaneus, please, that's when the patient will jump and say, yeah, right there, doc, it hurts right there. And those, if they're, again, that's going to be the older athlete where the tendon is a little less healthy, a little less flexible, they're going to get it right at the insertion. And we treat it kind of the same in the conservative way, which can be a boot or a brace or physical therapy, ultrasound, all those things will take place. But those insertional tendinosis of the older athletes are a little bit more difficult to treat. They'll take longer to get better. And the other key takeaway is that when there's a rupture, again, when there's a rupture at that non-insertional range, those can be fixed surgically or non-surgically, depending on the gap. But when you get a rupture at those insertional sites, it's almost 100% time it's going to have to be fixed surgically. So that's kind of a depressing thing for the, for the older athlete who comes in and, they'll sit down and they'll say, hey, I know I have a tear, but I know somebody who had one and they didn't have to have surgery, and I have to say to them, well, unfortunately, they were probably 20 years younger than you, and it was probably in a different location. While we treat the initial stages of the Achilles tendinosis, whether it be, non-insertional and insertional, kind of the same with physical therapy and everything we've talked about, once we get into the ones that just don't respond, or the ones with a tear, oftentimes if it's insertional, we kind of lean towards surgery. So that I kind of had to make obvious to everybody on Sunday when we spoke.
Yeah, that was really helpful to think about, because it's, you think about Achilles tendinosis, kind of a blanket term for everything, but there really is some differentiators that would guide your care for it and outcomes. And very similar also to lateral ankle sprains, our favorite thing that we all deal with. You had some great points about some key outcomes based on your experience, some key common areas that led to great outcomes in your experience. So what things should athletic trainers be thinking about when it comes to producing good outcomes with the ankle sprains that they're treating?
So one of the things that, you guys, in your world, you see, probably more of these than I do. I mean, they're just so common. But I always make sure that, we as professionals know the difference between a lateral ankle sprain, a high ankle sprain, and a medial ankle sprain. And we really need to differentiate that from the start. At Rothman, when a person comes in, if I have any suspicion whatsoever, obviously with x-rays, we'll look to see if there's a medial gap to indicate maybe a medial or a deltoid ligament rupture. We'll look to see if there's a spread between the tib fib to see if it's a syndesmotic tear. But x-rays don't always capture the extent of the damage. So we will send them for an MRI if we suspect. Because as you guys know, when you're treating a lateral ankle sprain, it's a whole different world than treating a high ankle or a deltoid medial ankle rupture. And so that's one of the things that I think that we need to, understand, that when the athlete comes into our place to treat them, do we know for sure that this is a lateral ankle sprain? Have we ruled out a syndesmotic tear, a high ankle sprain? Have we ruled out a deltoid ligament injury? Because, I have had people come to me as a second or third opinion, and they injured their ankle 3 months ago, and they were told they had a lateral ankle sprain, and they went through all the classic treatments and never got better and couldn't figure out why. And MRIs eventually, unfortunately, revealed that they had these other injuries. So that's number one. We got to make sure that those other injuries are not present. Once they are, the treatment, is pretty straightforward with these lateral ankle sprains. We know that the ATFL is the first one to go, and oftentimes the only one to go. And then the calcaneal fib and the posterior tail fib will go. But what we do is, let's say they come in day one, we have ruled out all these other injuries. We know they have a lateral ankle sprain. We throw them in typically an air cast, a game day splint, some kind of a splint. And sometimes they need a crutch to be non-weight bearing, but I have them use those splints every day for 2 solid weeks minimum. And then I have them come back and see me. At 2 weeks, a lot of their swelling is gone, their bruising is gone. They're starting to feel better. They don't need the crutches anymore. But I tell them that's stage one of the treatment. Stage two is going to therapy. And you guys know this, athletes are just notorious for, well, I feel better, I'm done. I don't need any other treatment. I'm getting rid of my brace and I'm going back on the field. And guys who end up with these lateral ankle instabilities, guys who end up with these constant chronic lateral ankle sprains are the guys who never followed up with therapy, never followed up with their trainers, didn't strengthen, and all those things. And that's absolutely necessary. And on top of it, when they are better and when they are going back to their sport, visiting the trainer's table, getting taped, keeping that ankle steady, because we don't want that thing to heal over the next 3 months with too much range of motion, because then they end up with ligaments that heal in a little bit of an elongated fashion. Therefore, the ankle's not as tight as it used to be, and they head down that pathway of chronic ankle sprains.
Awesome. Thank you for those insights. And it's always a great opportunity for athletic trainers, if they could see that acute injury right from the start and working collaboratively with you, especially for the initial pain relief, safe protective range of motion, that active care, it makes a huge difference in the long term. And you're right. Absolutely. A lot of times we just assume it's good to go and they jump in, and there's more to it than that. So the last thing.
I was going to say, you remember, like it wasn't that long ago where they told you as soon as you could walk on it, it was better for you to go out and play on it and strengthen the ankle. And now we know that's the opposite of the truth. Yep,
absolutely. You got to allow for that tissue to heal. So similar to that, plantar fasciitis, that annoying thing that we deal with, that you you basically mentioned, this is probably the most frequently mistreated condition that you come across. What are your suggestions quickly for athletic trainers regarding things to look for to guide their care of plantar fasciitis?
So plantar fasciitis is as the symptoms tell us, they'll have pain on the bottom of the heel, not the back. So it's not the Achilles, it's the plantar fascia. And the typical pain that they'll tell you is, they didn't really do anything. But they notice the slow sort of insidious onset of pain, where if they've been sitting for a long time, or typically they get out of bed in the morning, those first couple of steps are miserable, and then they walk on it a little while and it gets better, and then but it never goes away. And then eventually what happens is the pain doesn't go away despite them walking on it. The biggest mistakes are that people treat this thing by icing it, shooting up with cortisone, things like that. And while ice has its place, we all know that. But if somebody comes in and tell you they've had plantar fasciitis for 3 weeks, I don't know how successful ice will be. Right. And cortisone injections, as I kind of stressed on my Sunday lecture, they can lead you down to a pathway of rupture. So we need to avoid that. The best thing that people with plantar fasciitis can have, and I get neighbors and friends and people call me up and say, hey, what do I do about this? I don't want to come to your office. Tell me what I can do. Tell them to stretch. And the stretch has to be dorsiflexion of the foot with the knee in a locked position. Because if they do that, they're going to stretch their gastroc-soleus complex, they're going to stretch their Achilles, and they're going to stretch the plantar fascia. And if they bend their knee and dorsiflex the foot, they won't get the same stretch. It won't work. And I always tell people, you know, you're doing the stretch properly if you can feel it in your calf. And even though that sounds weird to a lay person, you explain to them, if you feel it in your calf, you're activating that gastroc-soleus, you're activating the Achilles, and that's going to lead into the plantar fascia. And you have them do that stretch for 10 seconds at a time, literally 100 times a day. And that's step one to getting rid of the plantar fasciitis. And the other thing they can do is check their shoe gear, make sure they're wearing a shoe that gives them proper support, make sure their sneakers that they're going out and running with are not, 12 years old. They have to have something that's decent to put on their feet. But if they have good shoe gear, a good arch support if they need, and stretching is absolutely the key. And stretching properly by dorsiflexing the foot, locking the knee, you do that, and 75% of the people with plantar fasciitis will never need to come and see me.
Awesome. Thanks for those insights, Doc. It was a great presentation, really a deep dive into foot and ankle stuff. Really appreciate your advocacy and support and collaboration with athletic trainers in what you do. And thanks for taking some time to hit those key takeaways today.
It's my pleasure, Ryan. Thanks for having me.
You're welcome. Have a great day.
You too.